Welcome everyone to today's session, the Arizona Telemedicine Program Connected Health Series. We have our crew here with Dr. Klotz, Dr. York, and joining us new is Dr. Perry. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. All right, as usual, your mics and your phone, computer mics were muted. Please use the chat function for questions and answers. We'll have that up, and Dr. York will be keeping an eye on that. We've got the post-webinar evaluation, which will pop up behind the screen. And this is being recorded, and it will be on our website later. All of our EMS folks, as you know, I will send out the email. And once you're done with the evaluation, please go ahead and let me know you'd like your certificates. And the university does use an attendance tracking code for CMEs. And those familiar with the CMEs, if you've already got an account, great. There will be information in that thank you email on how to set up your account. And of course, our standard disclaimer. I don't need to read it. And again, our website, of course, for future upcoming events. And again, your opinion is valuable. So please do the evaluation. And I'm going to pass the mic over to Dr. York real quick, but here's our presenters for today, and then we've got our little intro slides over there as well. Yeah.
All right, I'm glad y'all could join us again today. I think I recognize almost everybody in the chat so far. So it feels silly to do the usual introduction, but just in case if we've got anyone new joining us, this is an ongoing series that we've been doing now for, it's been almost 2 years now.
A little over a year.
It's flown by.
Yes, it has.
So already plenty of talks we've done covering envenomations, intoxications, all sorts of infectious issues here in the Southwest United States, focusing on the Sonoran Desert. So we've got some brand new stuff set for you this year. I think we've got a really interesting talk for you today. And then the next 2 sessions, I think, are already set. I think we're going to be bringing you rabies. And then right on going into summer, we're going to have another really exciting talk about rattlesnakes. And I cannot wait for that one for y'all. But we are joined today by Dr. Perry. This man does it all. He's one of our infectious disease providers, helps run the OPEP program, or does run the OPEP program. I help run it too. Partially, I suppose. But he is going to talk to you today about coccidioidomycosis or valley fever, followed by Dr. Klotz, who's going to talk about Basidio bolus that I wager not a lot of folks have actually heard of. All right, so I'm going to turn it over to Dr. Perry. Heroes should do it right now.
Okay, cool. So hi, everybody. I've actually never wanted done things. There's the camera. Okay, so I'm looking there.
You're looking at the camera, yeah.
Got it. Okay. So yeah, I'm Alex Perry. I do some infectious disease things every now and again, mostly often daily. Anyway, so I'm going to talk to you about coccidioidomycosis or valley fever. So for shenanigans.
2 minutes.
There you go. Now there you go. Now I should be able to do it for you.
Oh, gosh. All right. Okay. So coccidioides, the organism, because you know that coccidioidomycosis, the disease, the organism is coccidioides. So there's this paper that came out in 2023 by Speck and a bunch of others looking at the kind of the distribution of dimorphic fungi. So coccidioides is considered a dimorphic fungi. I'll talk a little about what that means. And basically there's kind of this regional distribution of it, kind of this like southwestern, like southern, I guess we're including part of Texas area, United States sort of thing. And more recently they're like, well, it seems to be kind of going outside of this like distribution pattern. So it's actually kind of leaving kind of its normal homestead and kind of spreading out there. Although so they kind of said you should consider more clinical and suspicion diagnosis. So I did my infectious disease training in Michigan, and it was funny when I was there was a running joke of how we'd always have cases of cocci that we never had, and then literally since I've been here, multiple people from my former training location called me about managing valley fever there. Although ironically, we'll see some of the kind of the spread of that is actually kind of the snowbird pattern. So we had people, as you sure know, if you don't know, and you ever out here during kind of the winter months when suddenly traffic increases, it's the snowbirds that come out here What happens, they go back to their southern state during the summers because they don't want to be here during the heat, and they're like, why do I have this, like, flu-like illness? So there's actually two different species, because of course there are, because phylogeneticists are a medicine must be stopped. So Coccidioides immitis basically is kind of the name that I think most people kind of think of, and that's kind of like the California disease. And there's Posavaceae, which is kind of the one that's actually in Arizona itself. So they have two different names, two different kind of geographic distributions, but they both cause the same disease. So there really is no difference. It's just a distinction without a difference. So it really doesn't matter. When we identify it by cultures, which is not common, it doesn't really matter. It's all usually it's like Posavaceae immitis, kind of a slash between the two. So here's where we talk about it being a dimorphic fungi. This is kind of what we're talking about. So it has these two different structures. So if we kind of start from let's talk about the top side. So the tubular structure emerges. It's in the soil. We breathe it in. That's really the big thing. Is it makes these arthrochondri that basically we breathe in. So when people ask how do you avoid to get valley fever, it's don't go outside or don't breathe. And so once we do inhale it, it kind of divides, raises intraspheral, builds an endospore. These endospores burst, and then the process kind of repeats itself when we kind of it gets out. But nonetheless, this is why it's considered dimorphic fungi, because it has these two different kind of phases of its life cycle. So epidemiologically, there's no more recent stuff. I think some of this data is actually several years old. So take this with a little bit of grain of salt, but know that it's probably a little more frequently is somewhere between 400 and 500 infected individuals, 400 to 500,000 individuals annually. But about half to a third are subclinical. So those numbers actually might even be underestimated. And within this region here, somewhere between about 20 to 30% of our community partners, our CAPs, are actually valley fever. And Arizona and California have about 95% of reported cases, and we actually win that one. So about 60% of those cases actually occur here. So take that, California. We may have less people, we have more cocci. And so climate change is going to be kind of a problem because as we have change in temperatures, a decrease in rainfall, it actually kind of allows for a more kind of region that cocci can kind of replicate and spread. And so basically, if these models are, at least when the models were first created, you're kind of see that purple area is kind of the danger zone area of basically having the temperatures and the decreased rainfall to kind of allow the thresholds to be met to allow valley fever to kind of spread. And as you see by the end by 2025, basically most of the Western U.S. will be or probably almost half the U.S. will be basically habitable for valley fever. So that could be a problem. No big deal. So coccidioides. So this is the disease itself. And really, this is kind of a breakdown, really, of kind of when we talk about this. So if 100 people get infected, about 60% of people are actually going to have mild symptoms or no symptoms. In fact, we see this actually quite often as people have these kind of like mild symptomologies. Usually, if you're born and raised in Arizona, you probably had valley fever at some point in time. Usually might get misdiagnosed as more of a flu-like, or pneumonia type illness that we recover from, and really you don't lifelong immunity after that. But about 40% of people do get symptoms of something, usually pulmonary symptoms. We'll talk a little bit more about later. And again, most of those recover. Some of them can have disease recurrence. And then from people, when they do get the initial infections, they actually get the more severe kind of disseminated disease. So that's much more rare. So the problem with this disease is it kind of has different ways of manifesting. And more frustratingly, basically, respiratory people, they're going to be fine. But we don't usually know that at that kind of when they present. But when people have primary pulmonary coccidioides, which is probably what we see predominantly, the one of the big things you can have fevers, chills, night sweats, and these last for actually quite a while, several weeks. If it can be, they can have cough, they can have joint pain, chest pain, headache is very, very long-lasting fatigue. And here's the big thing: the fatigue it's related kind of to the infection and like the immunologic process, but there's really nothing you can do about it. It's kind of there and it'll eventually go away. Something that I have to tell patients like daily sometimes, like this will go away. When? I don't know. but most predominantly what we can see is something called erythema nodosum. And so you can see kind of those two pictures there. Let's see this here. Yeah, so kind of up here, you can kind of see them spread on there, and then kind of the legs, these basically erythema nodosum basically just means like red spots, red nodules, really. And they can kind of be anywhere. Predominantly, we can see them on the legs. I've seen them all over the body. I've seen them on the upper arms. I've seen them on the hands. So they can be anywhere. These kind of big red, they can be like welts. They can be kind of like these small red lesions on the hands. They are usually ubiquitous within the first kind of presentation of the disease, and they're these kind of immunologic phenomenon. They will go away. Ironically, I've had, usually I don't see them in clinic just because by the time they get to see me, they're usually several weeks out, but every so often I had one patient who somehow slipped in and literally using some clinic. I'm like, oh, you have erythema nodosum. She's like, what? I'm like, these red spots. She's like, oh yeah, they'll start developing a couple days ago. I'm like, yeah, you have valley fever. What do I do? Nothing. And somewhere about 5 to 10% of people have these pulmonary sequelae. They'll talk about it in a little bit here. Really kind of there's some complications of primary disease. So I'm just going to go through some imaging here. So you have this pulmonary nodule. You're going to see down there. And really what this nodule is, it's kind of, you think about it as a scar. And so what ends up happening is people kind of get x-rays or chest CTs and like get this nodule, and kind of people can panic. Because the big thing that the concern with nodules can be a precursor for cancer. But what we can have is people, especially if they've had cocci in the past, is their body kind of walls it off. We never quite really get rid of it. Our body just kind of contains it. And so it can make these nodules. And so and people get biopsy, they're looking for cancer. They actually end up getting, they get the pathology and shows these spherules, let's talk about before. And then everyone's like, they had valley fever. They have no symptoms. They come to me and like, how you doing? I'm like, fine. I'm like, sounds good. But they can also develop pulmonary cavities, and those can be completely asymptomatic. Sometimes they can be symptomatic depending on where this cavity is kind of rupturing into. Treating these is kind of a bit of a nuance. Chronic fibrocavitary disease, these people can be quite symptomatic. Heaven forbid, this can actually happen. People can actually, if they get a heavy inoculum of the spores, they can actually develop acute respiratory distress syndrome. So basically they can just inhale and just kind of floods the lungs and they get incredibly sick. And then much like TB, you also have this miliary disease pattern. And again, these people are incredibly sick as well. So with both RS and miliary disease, they can be quite ill. So if you're seeing them in the field of the ED, be really more concerned about it. If we're seeing them in clinic, that's the worst place for them. But usually ours is going to be more of an acute presentation here. So it's usually going to see this with excavators or other people like doing some sort of soil work there where they just somehow get us poof of kind of sore in the face and get very, very sick out. I'll talk a little bit about the extrapulmonary manifestations. So they're relatively uncommon. We do see them. I see them more frequently because I'm an infectious disease doctor. And really what you have is you can have people have these kind of persistent skin lesions, bone lesions that go out through the skin, joint infections, even like a meningitis infection as well too. And those people are on treatment for a long time, and they actually have dissemination to the brain forever, because unfortunately no real treatment that cures it. So there's underlying risk factors. They can be immunosuppressed, tends to be cause more issues. There is a bit of I'll talk a little bit later about who gets treated, but other risk factors as well. But these people actually get normal chest X-ray and then no pulmonary symptoms. I've actually seen people like their primary presentation is actually with meningitis. And that's usually we have to kind of work that up to figure out what's going on. So diagnostics. So I was told not to belabor this too long, but I'm going to do it anyway because no one can stop me. So really the primary test that we think about is actually these over here, kind of these blood tests that we do. We could talk a little bit about cultures, but we don't do that too often. And just because it's not really, it's very difficult to get. Most times people aren't looking for it, or they don't send for cultures, and so it's only like kind of the pathology. And also it's kind of hard to grow. Now it's actually kind of a biohazard. Like they actually have to do a special hood, because you remember we talked about it's like in the soil and becomes these spores that people inhale. That actually happens if you grow it on a culture. So we have to warn the lab not to, for a concern for valley fever.
Once they identify it, don't they have to destroy it? They know that's what it is?
I believe so. Yeah. So I know they have the special hood downstairs that when they do it. And when I talked to Dr. Lanehart, I'm usually like, yeah, I'm very concerned for Coxie here. And he's just like, yeah, he usually appreciates if we're very conservative. Sometimes it happens surprisingly. We're like, oh, did not expect that. A little bit about the diagnostics. So I'm going to say just briefly, diagnostics suck. Really, because the problem of it is there's an antigen test that people can get, but we really don't have a good, the antigen test actually is very poor in most patients. It's very good in like people who have no immune system. So if you have an immune system, it doesn't really work. So we usually do serological tests looking for IgM and IgG. And so if anyone has knowledge about IgM, IgG, it doesn't work that way. The IgM and IgG actually go for two separate antigens completely. So you're not going to go from IgM to IgG. You'll get one and you'll get the other. And you can take several weeks to develop. So people can be acutely symptomatic and have completely negative serologies. And we get a test a couple weeks later and then they're positive. So usually what happens is we'll see people with these kind of persistent kind of like fevers, chills, sweats, pulmonary symptoms, and they've had negative workup so far. Repeat the serology and they will suddenly be positive. Like, oh, you've got valley fever. And or sometimes what happens is they're resolving. I'm like, the test we get like, you had valley fever, now you're getting better. I see a question. Should I answer that question?
Yeah, why not? Just
Yeah.
to save you on time.
Sure. Okay. So do you think rural areas get up most than city areas? I'm going to say anecdotally, I don't really see that. I think because the thing is, it can be in our soil here as well too, and people do garden. Lord knows I've tried to do it here in Tucson, and it's only failed in this week because the sun kills all my tomatoes. So I don't necessarily know that. I recall like I lived in the suburbs growing up, and I know I got it about in middle school. So I think it's just so ubiquitous in our soil. I don't really think it has a true like kind of urban, suburban, rural kind of predilection. I don't have any evidence of that. If anyone does, I'm happy to learn that. Anyway, treatment. So basically, it's treated only people who really have severe disease. Or risk of disease. So the older, immunosuppressed, diabetic, cardiovascular disease, pregnancy, Filipino African American descent. There's a genetic basically risk factor of people with Filipino and African American descent to get horrible disease. Like it sucks. It is just some sort of cruel nature trick. I've had to explain this to patients. I'm like, I don't know why this we know it has something to do with this property of their immune cells, and it's just horrible. Because there are some people who can get and have no issues with it, and some people just get horrible disseminated disease. And they're just because they came down here. But it's basically individualized. There's no clear algorithm of how we do this. And I would guarantee you, if you were to go to the Valley Fever clinic here, you're going to get 3 different answers. And it's not that any of them are wrong. It's just so nuanced that you're probably not wrong in doing certain things. And there's probably things that are probably wrong, but most time just kind of watchful waiting is not wrong. Neither is treatment, and neither is putting people on suppression. So it's just a weird sort of, there's no right answer, unfortunately. So just kind of a little bit how we treat it. So they get triazole, which is basically fluconazole. They're really severe disease. They get amphotericin and triazole at least for a year, and then if they have chronic infection, they get a triazole for about a year as well too. And that's again basically fluconazole. Fluconazole is basically the magic drug. It's one of this drug. I think I used it very infrequently when I was in Michigan, and like down here, it's just like it is probably the prescription I write the most because Larry writes all my prescriptions for the HIV medications. Yeah, so it's anyway. That is Valley Fever. Any other questions?
If you do have questions, we may lose Dr. Perry before the end. So if you get them, now's the time. We'll make up an answer if we don't know at the end. If you think of one later, we'll do our best.
That's the usual I make.
All right, so
what's the treatment? Okay, yeah. So fluconazole is kind of the drug of choice that we usually use. It's a great drug. It's a bioequivalent drug. So oral is equivalent to IV. So we can use it. 400 if you want to know the dosage, 400 milligrams tends to be the standard dose or adjusted for renal function if need be. Treatment for most patients, usually we do a minimum of about 3 months of therapy, because one of the unfortunate things about when you think about fungal diseases is they are kind of similar to our cells, and they're very slow dividing cells. So treating them is not this process that we can do quickly like we do with bacteria. they take their sweet time to basically get under control until our body can kind of control them. And that's usually what happens is these drugs are basically allowing your body to basically immunologically control it, because once you have valley fever, yeah, you have lifelong immunity, but you also kind of have it. It's there. There is always this considered risk factor of someone, they get it once and they get put on immunosuppression, that it can unmask itself. We don't see it happen as often as we think, because there are people who live here for all their life, no doubt have had valley fever, get immunosuppressed because of cancer therapy, or they get rheumatoid arthritis, they get immunosuppressed and nothing happens. And then there are some people who just, it seems to happen. So there's probably this multifactorial genetic process as well too. But it's, yeah, luckily the treatment's relatively straightforward. The big problems with it with fluconazole, the big things, one, makes their skin lips dry. So I've got people basically complaining that everything's dry, like they're, already our hard water here sucks, so everyone's skin's already dry anyway. And then you give them the fluconazole and they're dry, and they're like, lips are dry. And then when they're on for a long time, they get hair loss. And then they come back to me with dry, cracked skin, missing hair, and they're like, I'm going to kill you. And I tell them about this, they still are not a big fan of me doing this to them. And usually that's when we say we can stop, and they're like, great. And then hopefully they recover from spine, and they are very happy to never see me again. Which, thanks.
Let's say that you've got someone with presumably community-acquired pneumonia that shows up, and let's say like no erythema nodosum. Are there any other tells that you would want folks to be aware of to think maybe this is a bacterial or viral cause?
So that one's like kind of a tougher one. So I would say probably productive sputum might be a bigger indication, I would say. Because kind of the cough, shortness of breath, fevers, those can all be in basically acute viral syndromes as well as valley fever. The myalgias, arthralgias, again, very non-specific. So I would say if they're kind of like purulent sputum, like kind of that should be a red flag, because usually with cocci, I don't think, and you can say you've ever seen it, I don't think I've ever really seen people with truly like kind of this purulent productive sputum. So that tends to be more of a pneumonia type syndrome. And then sometimes, well, they have kind of a preceding URI before that. So, most people don't develop just straight pneumonia. They tend to have some sort of preceding other syndrome that comes before it. It tends to be with valley fever, it tends to kind of feeling crummy and then going straight to pneumonia. Because it really doesn't have this like, it creates like more of a disruption in kind of the upper respiratory tract membranes that kind of leads to a pneumonia development. So I think kind of thinking like how I've seen it present in terms of the patient's respiratory, those are probably the two things to think about in terms of like, this. But this is why ID is all about active history.
What's the age that gets it the most and the sex of the patient that gets it the most?
About 50-50 male and female. Age-wise, I don't know if there's a true distribution pattern that I've seen, because it really the ages whenever the hell they come to Arizona. So I say this like, so, but I will say, so for probably most people who lived in Arizona all their life, they've probably gotten it within, usually most people get it by their 20s. I've had a couple of patients that have gotten it at a lifelong person. She was from Yuma. She got it at about 25. That's probably the latest. Most of us probably, if you've lived your whole life, you got it relatively young. I know when I got mine, because there was probably one of the worst like summer monsoons we've ever had. And I walked to a friend's house because I was never a smart child nor a smart adult. I literally like within like a week and a half later, I was like super duper sick. And I was like, oh, that seems to be a dumb thing you've done. And I was like, yeah, sounds about right. So I lost a week of summer. But I recovered from it. And I've been tested for that. I have like the IgG, so I'm like, all right, well, I definitely had it. So yeah, I don't think that I yet to see any true like distribution. There, if you probably looked at some of the data, you might see a maybe higher male predilection for it, only because of like kind of like exposure to like kind of dirt-based jobs, so construction, things like that, excavation, that might be an exposure. But I would say of the patients I see, there is no particular gender switch to it. The age issue. The age issue is just more, I think, of when people present. So with people, as you get older, the immune system can decline, so you can have recurrence then. So that can be one of the issues. And I see that question over there. Basically, once you get it, you have lifelong immunity. People tend to get recurrence; they don't tend to get reinfected. anecdotally, you probably can find one or two people who've like got it once, then got it again with acute pulmonary syndromes, but like those are so rare that it's like they're more case reports than actual factual data. You need to keep that back in your mind. So most people, once you've gotten once and that's it, you're a lifelong.
So it's kind of like the old school chicken pox.
Well, yes and no, because you get shingles.
You can get
You
shingles
don't
later.
get toxic shingles, at least not that I'm aware of.
Okay.
Yeah, so it's more than likely people will get like it tends to be more of a recurrence in kind of pulmonary symptoms or just more severe symptoms in terms of like the immune response to like a malaise, like kind of syndrome that I've seen with it when they do get like true recurrence of it. But that's again only the thing of like this immunosuppression thing, and it's likely that they had acute valley fever before, and so I think they're more recent. I think if you've gotten it like 20 years ago, probably anything they do in terms of like suppressing your immune system for whatever reason, or as you get older, it seems to be fine.
So is there any research on a vaccine for it?
There is research on the vaccine, which I do not know enough about to speak of.
I mean, a vaccine that can actually keep you from getting it.
Yes, there is work on it right now. I swear Dr. Galgiani has gone on about it multiple times now. And every time, but like, I know it's like in process and
I think the grant's been scotched.
wow, that's a different thing, which is, yeah, but
Let me ask you a question.
Yeah.
What about the serologies? How good are they?
oh, they're not, they're horrible.
Oh, great. Maybe
Well-
you could explain that.
So they're really, so with any infection, like when you want to have a good test for infection, you want to know like what the positivity of them. I mean, actually, my slides are gone. Anyway, so one of the reasons why they're horrible is that, so if you have like a low immune system, like so people who've been massively immune suppressed, the serologies are worthless because they're not going to work. So they're not going to actually create the antibodies you need for it. So that can be that. There's a delay in the response to them. So again, I've actually seen it happen when people actually have very severe disease, incredibly severe disease. Their testing is negative, and then a week and a half later it's positive, but they have no other signs or symptoms. They just have this kind of very severe immune response that we haven't quite figured out yet. And then turns out it's actually valley fever the whole time. That's incredibly frustrating. There's one of supposedly there's kind of two different tests. There's the EIA and the immune diffusion. I guess my reverse here, I don't know. So the EIA is kind of the screening test. And then the immune diffusion is more kind of the reflex to confirmatory test. So my favorite thing about that is, so the screen test will be positive, the immune diffusion is negative, and you're like, oh, what does that mean? And it's like, we don't know. My favorite thing though is the IgM on the EIA test is notoriously a false positive, like universally, like it's well known. If you get it kind of in a like by itself, you're just like, I'm just looking for valley fever in this patient. It can be positive and they'll be asymptomatic. And you're like, what, this person is positive IgM, I don't know what to do with this. And you'll send it to us and like, you did a week. But if you like people are like symptomatic or they're like other signs, other things you're concerned about, that's when like you want to actually follow them up with that. And so there's a really good paper by Janice Blair that really goes into kind of like doing it right. But it was hilarious. There's like a couple of years where basically these fighting papers on how bad the serologies can be in basically certain populations. So it's important. It's the kind of the fastest test we have because the true gold standard test is culture, which we just can't get because very often we do have someone who do cough up something from us. They actually can grow cocci on a culture, but we don't get that often. And most people, again, like they're going to present with this acute pneumonia. And by the time you can test them in the ED and you might catch a couple of them there, depends on, it can depend on how people, depending on like if the tests are positive. But then by the time like they have follow-up, they're like with the doctor, they can actually already be better. And you're like, okay, well, we can repeat the test, know that it was cocci. Temperature environment effect and how people get it. Yeah, dry is probably the big thing. And that just leads to more aerosolization of it because it just, usually it tends to happen. I believe we'll have like a good monsoon season, then we'll have just basically incredibly dry season. So basically you'll have a lot of the spores will be made and then just like go out into the ether and spread the infection as people go on these, outdoor hikes.
So I'm thinking of the summer storms when we get those haboobs coming through. And now, so whether it's rural or in the city,
Yeah.
all that dirt is just
Goes
through everywhere.
Yep.
Okay.
So as I said, if you don't want to get valley fever, if you've never had it, don't come, apparently I will say by the end of this century, don't come to the Western United States. Or don't breathe.
Or don't breathe. There we go.
Those are your two, unfortunately, those are your options. And so But again, as with most people, vast majority of people will recover from this. And so it's more you have to keep it in the back of your head in terms of presenting, because the big thing, especially when we talk about for acute bacterial pneumonias, or is that when you have like about a third of patients are going to have this valley fever, basically you can throw all the antibiotics you want at them. The only thing you're going to do is, one, people have a reaction to the antibiotics, two, potentially a C. difficile from that, three, to find out, get the horrible irritable bowel disease after getting all those antibiotics, and four, still not have a resolution of their symptoms. And so basically, I would say basically if usually what happens if there's a paper that came out, I think it was like usually people got like 2 courses of antibiotics before they test for valley fever, and it's just like keeping a very high, suspicion, like especially I would say if like we've had particularly in the last couple weeks, like a very windy season, a very dry season, or people are newer to Arizona, like that should be one of your things to trigger. So if people lived in Arizona in their life, probably lower suspicion would be there. But I would say a vast majority of people that I see are a lot of people who have just moved to Arizona in the last 5 years, or people who have been like kind of the snowbird type thing, or seasonal visitors here. Those are the people who I tend to see more get kind of more of the acute syndrome at like kind of a later stage, because they've not really been exposed to the environment.
So everyone's gonna get it, you just gotta live through it.
I unfortunately, yes, I have not, it is unfortunately death, taxes, and valley fever are the.
There we
the
go.
three
All
symptoms.
right. All right, do we have any other questions? We've got, thank you for the questions in the chat right now. We got them all. All right, and with that, thank you very much,
Everybody,
Dr.
I
Perry.
apologize for having to run, but the clinic demands.
That was awesome. Thank you.
All right, and as our docs switch over here, we're gonna go ahead and pull up Dr. Klotz's file. And Dr. Klotz, I don't know if you saw me, I switched out, hopefully we've got the videos
Okay,
with your new updated slides. All right, hold on a second here, Chris, you want this one? We've got sound, we've got a couple of videos here for Dr. Klotz. It's down, it's over here. You can see those all right? All right.
good.
Let
Okay,
me pull our chat window over so Dr. York can manage that. And here we go. All right, so you should be able to go ahead and connect with.
I use
your-
this
yep.
keyboard.
Yep.
Yeah, if you want to do the mouse, you can do either one.
Okay, well,
And I'm
thanks a
gonna
lot,
zoom
everyone,
in.
for signing in today. And as Larry explained, we've been busy trying to present different diseases and intoxications and poisonings over the last couple of years. And so we're getting to a little more rarer things. Fortunately, or unfortunately, coccidioides mycosis is not rare in Arizona or in California. However, this next disease that I want to talk about just briefly, which is Bacilliobolus mycosis, caused principally by this one fungus called Bacilliobolus rhamnorum, is pretty uniquely confined to the state of Arizona, at least the gastrointestinal form of the disease. And one of its relations, Candidiobolus, is actually found on the East Coast on the seaboard. But let's look at why it's called this and why it's kind of interesting. And I'm going to show you a video that deals with a related organism called Polobolus, but it propagates its spores in the same manner that Bacilliobolus does. Okay, so let's watch this first one here. And I think if you don't have sound,
Grandma made her thing up.
Why is everyone always feeding me?
Just get my back if I ever need it.
we don't have any sound here.
Here at Earth Unplugged, we have filmed
But
the
these
fastest
two
animal
guys-
on the planet, which is the peregrine falcon, and can reach speeds of up to 300 kilometers per hour in full stoop. But is it the fastest living thing on the planet?
Well, it depends what we mean by fast. Bigger things tend to cover greater distances in shorter time frames. But if we're talking acceleration, then this is quite a good contender.
And not the poo, we're talking about a fungus. So this rather nasty looking specimen that we have here is exactly what we're looking for, and it's a genus of poo-loving fungi called Pilobolus, and their reproductive cycle involves being eaten by herbivores, digested and then pooped out, where they will then grow on top of the poo.
Yeah, and you sort of got it right there. I mean, it's grass-eating herbivores, so obviously when they're on the poo, they need to get out of the so-called zone of repugnance.
Very nice.
And to land on grass, and then the cycle will begin again. So all these spores at the end of the fungus need some serious firepower to get away because they're so tiny and light. So hopefully we're going to try and catch that, and they should have some incredible accelerations for us.
While the cultures are growing, let's go shoot some other stuff as a comparison. I'm super excited because we have come to a gun range to try and demonstrate just how fast these Pilobolus fungi spores really are. This is going to be our first contender. It's a replica Remington rolling block. It's chambered in .45 caliber, and it's got a barrel length of about 34 inches.
And this is what's coming out the end of it. It's about 530 grains, or about 34.3 grams. So using that information, we can work out the acceleration and momentum of the bullet, and then compare that to the Pilobolus. So due to various gun safety laws here in the UK, it's not going to be us that are going to be firing.
Sadly.
We've got a firearm specialist.
For the best.
For the best, I think, definitely. I think we're ready to go here. I can't believe I jumped.
Next up, 12 ball, over and under, shotgun.
Very gorgeous, and this is what is coming out of it. All these tiny little bits of shot, and even though they're very small, some shot can be up to 100,000 times heavier than a Pilobolus spore.
Wow.
So they've got much more momentum. Let's get cracking on this one, I think. So the guns are good fun, but we're now back in the studio with the main star attraction, Mr. Pilobolus.
You can definitely see that there's some on there now.
Yeah, they're growing up and looking fit to burst. So now we play the waiting game.
I've been sat here for the last 3 hours waiting for fungi to discharge their spores.
So we're currently shooting almost 22,000 frames a second, which gives Sai just over 1 second to press the trigger. But in terms of the Pilobolus spore actually discharging, apparently it reaches top speed in about 2 millionths of a second. So we won't really even see it go. We'll just see the spore disappear.
Hey!
Hey! Nice one, Si, that's awesome. You little beauty. So I mean, that's huge sort of bulbous end of the hypha, it's called, or the stalk. Basically, it's just filled with cell sap and cell juice because it's built up through osmotic pressure, so it's sucking up water
Building
into
up.
that end, and then finally it just goes. So in terms of their velocity, they're so small. In fact, the distances relative to their size are vast. So in fact, their top speed's not that impressive. They've been recorded going about 25 meters per second, but they reach that top speed in about 2 millionths of a second. So
Wow.
in terms of the accelerations they're pulling, they've been recorded about 20,000 G.
Yeah.
And some fungal spores have been 180,000 G.
That's insane.
It's completely insane, yeah. And the secret behind this success is a really high internal pressure in that sort of bulbous bit at the top of the hypha or stalk.
Positive.
Okay, so I think you can hear me now. Unfortunately, due to the link up here, we couldn't hear any sound, so I was explaining to Larry and Melanie what was going on in the video, but you could see very graphically that this spore forced out by osmotic pressure from the sporangiophore just accelerates unbelievable, twice that of a bullet, if you can believe this. And it is believable because they're actually measuring it. But this allows it to spray spores throughout the area away from where it's growing and decaying matter, which is principally where it is. Okay, so I had always had a very big interest in conidia, which is what we're talking about here, these little spores and their propagation. And one of which I studied quite extensively was Aspergillus, which you're all familiar with. This is a fungus that's found and actually counted on our spore count in the air. And it is small enough that it can aerosolize. And the other feature that it shares is that its whole surface, the spherical surface of the conidia of Aspergillus, are amyloid. So the whole surface is very hydrophobic. It can go and then aerosolize, not droplet nuclei like flu and other ways we pass disease, but this one just participates in air currents and will remain airborne for hours. So let's take a look at that, at least briefly. Melanie.
That's this one, right?
Yeah.
I think you said this one didn't have some.
No, this one doesn't have some. So that's fine. Okay, so you couldn't hear me talking here about what that second video was about, but that was Aspergillus on a conidiophore that was releasing small conidia, or spores, if you will, into the air. And you could see how they remained airborne and just moved around with air currents. And this is due to the hydrophobicity of their outer surface. And so if it were moistened like the city of Bolus or something like that, it would have eventually fallen. But this one, you can count on it going on in the air for hours. So the city of Bolus, getting back to it, this fungus that is pretty well confined to Arizona in the United States. Otherwise, it's found in India and tropical and temperate regions of Africa and other areas of the globe. But its close relationship called Conidia bolus, which does the same sort of thing of sending out a ballistic projectile, is found on the east coast of the United States, particularly in seacoast areas. These are both saprophytes, and the B. Renarum was found originally in frog feces. It's also found in other cold-blooded vertebrates. It causes subcutaneous infections, principally in temperate areas of Africa. In Arizona, the same fungus is found. It's somehow gained a niche here in Arizona. It's associated with intestinal mast-like infections or gastrointestinal Conidia bolus infections. Next slide, please. And here is Conidia bolus. It is inhaled. Those spores are inhaled, and they have a predilection for causing rhinocerebral orbital infections like you see here, which are destructive and eventually fatal. And interestingly enough, we've talked about now 3 different diseases which occur almost entirely within the state of Arizona. The other one was an amoeba, a soil amoeba that Larry had talked about, which was Balamuthia mandrillaris. And another unique disease, if you will, unique to Arizona, was one that I talked about some time ago, Onchocerca lupi, which was transmitted by black flies up in the area near Lake Powell. And it caused these mass lesions around the central nervous system. Well, here is Canidia bolus, and you can see that if we were to see that today in the hospital here in Arizona, we'd want to know, is this a mucorales infection, like from mucor? And as I put down there, Balamuthia mandrillaris. Next slide, please. And here is the subcutaneous disease where the canidia are injected traumatically underneath the skin. You can see these dark areas on this, I think it was a 5-year-old child. And we have not seen this in Arizona that I'm aware of, the subcutaneous infections. But it has a predilection for adipose tissue, and the lesions are actually mobile. They don't attach or invade the underlying tissue. They're just found in the fatty tissue. And this is why they're kind of distributed as they are in the bathing trunk region. Again, it's found originally in the feces of amphibians and reptiles and fungus. And next slide. If you biopsy tissue, what you see are these very characteristic lesions on H&E, which are called Hepley splendor. And basically this is eosinophils around probably some remains of the fungus itself. And they're presumably what is happening is that immunoglobulins are precipitating all around in the heavy deposition around the fungal elements and give rise to this beautiful picture. And it's actually, it's kind of important diagnostically in that patients who do not manifest the splendor Hepley phenomenon usually don't do very well with Balamuthia. Maybe an indication that they don't have the appropriate immunoglobulins. Next slide. And the treatment, it's very successful. If you look in Wikipedia, I mean, honestly, sometimes I get so frustrated with Wikipedia. It has like, well, let's see, iodine treatment.
The potassium.
Potassium iodine, good heavens. But it actually responds to itraconazole, not so well or predictably well with lipid amphotericin B, which is basically the only fungicidal drug we have in our armamentarium. All the imidazoles are fungistatic. And they have something to do with what Alex was talking about. Time it takes to get a response. Okay, next slide. Thank you. And this all came to my attention when I moved down to Arizona in 2000, because there was a recent paper in the Mortality and Morbidity Weekly report in '99 that there were 6 cases of this gastrointestinal disease in Arizonans. And then later, Mayo wrote a paper, their ID docs, about 17 cases from Arizona. And all of them were gastrointestinal Acidiobolus. Okay. And so the classic presentation for the cutaneous disease is on the buttocks and the thighs. as said to have a bathing suit distribution. The nodules of Basidio bullous cause erythema and warmth of the overlying skin due to the inflammation. The subcutaneous lesions are typically attached to the overlying skin, but not to the underlying tissues, so they remain freely moving. And here was a summary of the gastrointestinal Basidio bullous infections from the 1999 report. So you can see the anatomic structure involved is mainly the colon. So it looks like it's either adjacent to the mucosa. There's been a breakthrough, but rarely. And it looks like a cancer. And however, there are some clues that you know immediately you're dealing with this. And that's the exciting thing. And I got to make this diagnosis, oh, I don't remember, 15, 20 years ago on someone in our hospital here, was they had intense eosinophilia, like 20,000 eosinophils. And there's tissue eosinophilia as well. And on biopsy, you can actually see the fungal elements. And it's really easy to diagnose if you think about it. And whenever you find some of these other features like splendor or Hepley, consider this as one of the causes, as it's seen in a number of different diseases.
Would anything else cause the Spender Hepley phenomenon that you can
Oh,
think
yeah,
of?
there's a whole list of organisms. It's most commonly seen in sporotrichosis. And so you'll see it, and it's just a tip off to problems once you see it, or the pathologist is going to see it first. And so this is really an interesting disease. I think that's the last slide.
Oh, just
Just
a
summary.
Oh, okay, so this is a rare mycosis found almost exclusively in Arizona within the United States. It's now found in pediatric cases worldwide, subcutaneous and gastrointestinal. The GI disease mimics cancer. That's the big thing for us here in Arizona. Mimics cancer, or on occasion there's been bleeding, rectal bleeding with what mimicked inflammatory bowel disease. So the canidia of Basidio bullous are probably swallowed for this gastrointestinal disease. And there's a traumatic injection of canidia under the skin in these children in cutaneous disease. And as mentioned, there's a predilection for adipose tissue. The fungus possesses several enzymes, proteases, and so forth, some of which act like cellulase, but are rapidly tearing down subcutaneous tissue. And there is always a prominent eosinophilia in the tissue and in the peripheral blood count. So this is the tip-off. Once you see this eosinophilia, even with coccidioidomycosis, eosinophilia, peripheral eosinophilia can be seen. So this is just one of many presentations of eosinophilia. And we've had several here in Arizona, which are unique. And I think I talked about that one time.
I think
I'm not
we
sure.
covered it a little bit.
Yeah, we had not only fungi, parasites, particularly more advanced parasites, not the protozoans. Okay, so this was just meant to be a filler for Dr. Perry's presentation, which I think covered very nicely this common fungal illness. This is just an oddball. But if you see these combinations, eosinophilia, cancer of the GI tract, you know right away, this should be considered.
And we've got an interesting question. So
Okay.
similar question was asked of Dr. Perry, but do you think the dry climate is what's bringing out these different presentations from what you may see worldwide? Like not seeing the the subcutaneous aspect, really seeing the GI aspect?
No, I favor most of this, I don't describe everything to, warming climate and all this kind of stuff. And furthermore, the predictions or the calculations of what's going to happen remind me of the foolishness that went on with COVID-19 when it started. It's going to take over the world. People just get carried away with their models. But the Basidio bolus, I'm not sure, Larry, what's
The explanation.
the explanation here, that's for sure. But it's, I don't really know. I mean, maybe with time we'll learn, but it's more likely that people have moved into areas where the fungus has been, are exposed to it where they weren't before, because we've got our population has enlarged tremendously, and we have people moving into the desert all over the state, as you know. And it's a big hazard for running into kissing bugs and rattlesnakes. I don't think rattlesnakes are any more popular. They might even be less populous, but yeah, we'll find out from our talk coming up in, what is it?
I think that'll
May?
be May.
Yeah.
I'm excited. We got some exciting ones to look forward to. We've got just a few minutes, so if anyone's got any questions, valley fever, coccidioidomycosis, Basidio bolus, now is the time. I like this idea of combining a very well-known thing with a very unusual thing.
Okay.
It's a nice,
Yeah, if
nice
we did
mix.
all unusual things, everybody'd say, this is all just nitpicking stuff. But actually, as clinicians, and many of you are, it's the fun stuff too, because
Yeah.
you're walking by and you just go like an Augenblick, a flash of the eye. It's just, wow, I know what this is. It could be Basidio bolus. And as long as you're making rounds here in Phoenix or Tucson, you could be correct.
Very exciting.
Again, another very entertaining session with Dr. Klotz and his crew. And we do have a couple of sessions coming up in April and May, and I just sent out those flyers and the information yesterday. I believe it's the 23rd. They're both on a Wednesday.
So I'm putting them on my calendar right now.
Okay. Yes, because we need to make sure you're here as well. All right, and a evaluation will be popping up. And again, everybody that's been, thank you for sticking around with us. We still have a lot of attendees. I will be sending out that thank you email with the directions on responding and getting your certificates. And thank you, Chris, for putting the evaluation. He just put that into the chat. That'll also be in my thank you email. And any of our crews that have your groups together, some of the first responders, I know that you have some of your in trainings that you do together as a group. Go ahead and send me that list of the participants that were with you, and I can get their certificates out to them as well. And with that, we are going to give you 1 minute back to your day.
A whole minute.
A whole minute.
We are gift givers, that's for sure.
And thank you again for joining us, everybody. We look forward to seeing you in April. Take care, everyone.